this is probably a good time to go through the subtypes of MS. So we have characterized MS into 4 different subtypes. And we did this characterization so that we would all be talking about the same form of the disease when we would have conversations. And so we could develop more homogeneous groups of individuals for studying MS, because the more homogeneous the group you study in a clinical trial, the more likely you are to be able to determine a clinical effect that's unbiased by your sample. These characterizations were not designed to be used for characterizing severity of the illness necessarily, although there's some correlation. It doesn't have to be the case. And so probably doesn't fit in as well into a managed care context, although we can come back to that. So the characterizations that we've utilized are relapsing-remitting, which is the commonest form of MS. Individuals have an acute attack of something neurologic, whether it be optic neuritis or brainstem cerebellar syndrome or a partial myelitis, from which they have dysfunction from days to weeks, and then they have a recovery period in which they will recover anywhere from 0 to 100%. And so they may make a full recovery, they may be left with some residual deficit, but in between that attack and the next attack, they're stable with whatever their deficit was. The next attack could occur weeks, months, years, or decades later, or never. But that's the issue of relapsing-remitting. The second phase is called secondary progressive, and that's relapsing-remitting patients who at some point transition to where in between attacks there's gradual worsening of the neurologic status. It's not inexorable, and it's not a straight line. It could be jaggedy, they could be stable for periods of time, but it's one of the progressive forms. And as was alluded to, we think the progressive forms are where individuals develop the most disability. Third type we talked about was primary progressive MS, which are individuals who don't have an acute attack, never have an acute attack, but instead start out with gradual worsening. That is, they start out in the progressive phase of the illness, and they also develop considerable disability. And the fourth subtype was called progressive-relapsing, and that's individuals who start out in a progressive form, but then go on to have acute attacks that are just like anybody else's acute attacks. And we now know they occur in a small percentage of individuals who have primary progressive MS. Since we came out with that characterization, 2 other clinical courses have come up. And you want to say a little bit about CIS and RIS?
So this is very interesting. The vast majority of MS patients start out with relapsing disease. Well, obviously, they have to have their first relapse. At that first relapse, there is no neurological history, so you can't be sure of the diagnosis. That first relapse is also referred to as a clinically isolated syndrome, or CIS, and that by definition is a CNS inflammatory syndrome attack. The classic examples are a monocular optic neuritis, a brainstem cerebellar syndrome, a spinal cord syndrome giving you a transverse myelitis, a partial myelitis. That first attack carries risk that it represents the presentation of relapsing MS. You can actually work up patients and develop a profile of saying this is a CIS patient who is at high risk for MS or low risk for MS. For example, does their brain MRI show silent disseminated lesions that you would not see except in an individual that had a neurological disease process? So for example, the individual presenting with an optic neuritis, you would want to know, what does the brain MRI show? If it shows silent lesions that look like MS, that's likely their first relapse of MS. It's certainly getting that person very early, and you would thoroughly work them up. You can look at their spinal cord, you do blood work, you do spinal fluid, you'd make sure there's no other better explanation than relapsing MS. And actually, there are 5 phase 3 trials that indicate such patients do better on an MS disease-modifying therapy than not. Moving the field forward and to talk about a really puzzling feature is something called radiologically isolated syndrome, or RIS. This is perhaps asymptomatic, pre-symptomatic, or silent MS. What this is referring to, and it's only been described in the last couple of years, with a plethora of MRI scanning available, patients will get MRI scans for things like headache, or they were in a motor vehicle accident and they're complaining of some pain or perhaps some stiff neck, and they get an MRI scan. And lo and behold, shockingly, it's abnormal. And it shows lesions that look like MS, yet there's no history. They didn't have a clinically isolated syndrome. They have no neurological history whatsoever. What are the possibilities? Well, it's possible they don't have MS and something else caused those lesions, and the lesions could be historical. It's possible that they have MS, but it's going to remain silent, as I spoke about the autopsy studies. Or it could be that they have MS, and this is a prelude. They're going to have their first attack in the next couple of years, and in a very large series of several hundred global RAS patients just presented at our big last meeting, over a 5-year follow-up, 34% had further clinical presentation. So now we're needing to deal with this so-called possible silent MS or pre-symptomatic MS, moving the potential diagnosis even earlier than the first clinical attack. So it's amazing and very complex.